Well, it's good enough. I done. Let's do it.
All right. Okay, hi, we are live. Welcome everybody to today's live session. I'm Taylor Player, your community manager here at Gainswave. Thank you so much for joining us for this Facebook Live with Dr. Brandeis. Today we'll be discussing PRP and stem cells, but as more people log on, let me just give you a quick rundown of some updates that are going on here at Gainswave. This April 2nd and 3rd, you can gain a competitive edge over your competition and learn sales, marketing, and operations from the experts. You could learn how to master it all in this intensive 2-day mastery workshop. You'll work closely with our team of experts and gain valuable hands-on training and insights that you can implement immediately to accelerate growth in your practice. So that's April 2nd through 3rd, and you can come down to Miami, Florida and make a trip out of it, but it's a really exciting workshop, and like I said, you can go back and implement it immediately, implement everything you learn immediately into your practice. So go to practicegrowthworkshop.com to find out more, or email me at taylor@vitalityconnect.com. And just a couple more things. Before we get started, so we go live every week with a new topic, and Dr. Brandeis has been awesome in providing us with these medical topics and these journal clubs that provide continuing education for all of our providers. So during this live session, feel free to ask questions as they come up, and we'll get to them at the end of each article. So there are 2 total articles today. And if you have any follow-up questions after the live session concludes, please feel free to post them in the group, and then we'll answer them there. If that sounds good, give me a thumbs up below, and we will hand it off to Dr. Brandeis. Hi, Dr. Brandeis.
Hey, Taylor, how are you?
I'm great. Very excited for today's session.
Yeah, me too. You know, these journal clubs are a lot of work, especially for me, but in private practice, it's good to push yourself to read the literature on the new techniques that you're using, especially in something like sexual medicine, a regenerative sexual medicine that we're doing. Everything is so brand new. There are so many people doing things that are off the shelf that don't necessarily have the data. And so it's important really in what we're doing to know exactly what the information is out there and what the information is lacking. And so I thought it would be a good idea to review some important papers on PRP and also on stem cells, because a lot of people are using PRP, a lot of people are using stem cells for all sorts of different things. And sometimes people feel bad, like, well, I'm not doing a lot of PRP, or I'm not doing stem cells, and all these reps keep coming around from all these different companies saying, this guy's using stem cells, or that guy's using stem cells, or these people are getting amazing results from using stem cells. You know, the guys' penises are growing 12 inches every month from using stem cells, or, you know, they're getting porn star erections from PRP. And sometimes you feel bad, like, well, you know, my guys aren't getting those kind of results. Maybe I should call up the stem cell people and start using the stem cells. And so I wanted to review what is the actual published literature, not the anecdotal stuff, not the stuff that the sales reps tell you, or the stuff that you hear at meetings, or the stuff that people say when they want other people to think that their results are amazing. But let's go and see what the actual reviewed published literature is on PRP and stem cells, so that you can feel better that you may not be doing as much of this as your next door neighbor, or maybe you are, who knows. But let's just delve right in. Oh, that's not delving in. Come on, with that lead in, I needed something better than that. Come on, it's a slideshow. Should be able to go.
Maybe just press your back arrow.
Okay.
Yeah.
Ah, there we go. No. Why on earth is this doing that?
So if you scroll.
This is my last slide.
Mm-hmm.
I should be going for my first slide.
There we go.
There we go. See, that's what happens when your first slide and your last slide look almost exactly the same. So anyway, for those of you who don't know who I am, I'm Dr. Judson Brandeis. I am the Director of Clinical Excellence for Gainswave. Really exciting news. The SWEET study next week will reach 156 patients. You may be scratching your head and say, why on earth would he care about 156 patients? But the paper by Kittrey has the largest number of patients in a shockwave study, a single shockwave study. And the SWEET study next week will reach 156 and probably 157 patients, which will make the SWEET study, which is filled with Gainswave providers, the largest single study of shockwave therapy for erectile dysfunction ever. And we will keep going. So think about it. Our community of physicians and healthcare providers will now be participating in the largest study of shockwave therapy ever done. And so those of you who are contributing patients, thank you. For those of you who have high volume practices who would like to contribute patients, please contact Dr. Scott Liu at research@BrandeisMD.com. And for those of you who are Affirm Science customers, thank you so much, because your business is helping to support basically the sole support for the SWEET study, so that we can spread the word about how amazing Gainswave is for the treatment of erectile dysfunction. Okay, so let's go. The first study is out of the People's Friendship University in Moscow, Russia. Now, most people don't consider this like the epicenter of sexual medicine research, but they wrote a really interesting paper, which is platelet-rich plasma therapy for male sexual dysfunction, myth or reality. It appeared in Sexual Medicine Reviews 2019. So less than a year old. This is fresh, hot off the presses. Okay, for those of you, just a quick review, platelet-rich plasma is autologous blood plasma. The plasma concentration of platelets should be 3 to 7 times normal. The therapeutic effect is greater when it's 1 million units per microliter. I don't know how they got that number, but that's the number they put out there. PRP, as we know, is used extensively in cosmetology, the vampire facelift, sports medicine for knees, shoulders, hips. It's being used in cardiology and trauma surgery and plastic surgery and tissue engineering, nerve restoration, type 2 diabetes, the list goes on. But most importantly, there are no standardized protocols. So there's no one out there saying, this is the standard. You know, you need 2 times normal, 3 times normal, 7 times normal, single spin, double spin, 7 cc's, 11 cc's, 22 cc's, 60 cc's. I'm just thinking off the top of my head, all the different kits and preparations that I know of. So it's all over the map. So when someone says PRP, like, who the hell knows what they mean? It could be a single spin. It could be a double spin. It could be 2 times platelets. It could be 7 times platelets. It could be activated with calcium. It could be not activated with calcium. It could be 7 cc's. It could be 60 cc's. It could be 22 cc's, but 22 cc's and a guy with a platelet count of 100 is going to be different than 22 cc's with a guy with a platelet count of 300. So there's no standardized protocol. And so in the clinical research study that I'm going to do on PRP, we're actually going to measure platelets and we're going to measure VEGF. And I think my caveat in the beginning anyway is, if you're going to do a study on this, make sure you know what your concentration of growth factors is and what your concentration of platelets are. Okay, so composition of PRP, the important growth factors are vascular endothelial growth factor. And one thing that I learned from this article that I picked up is that there are different VEGF receptors, and the different VEGF receptors, they do slightly different things. And I'm not going to go over all that kind of stuff because I'm not a biochemist, but there's VEGF receptor 1, 2, 3. There's something called neuroprolin 1 and 2. And so VEGF attaches to those different receptors and they do slightly different things. There's also platelet-derived growth factor, which helps stimulate angiogenesis via the VEGF pathway. There's fibrin growth factor, which activates vascular smooth muscle, among other things. There's epidermal growth factor, which is a vascular smooth muscle growth and promoter, which helps with vessel maturation. Insulin growth factor, which leads to proliferation of endothelial cell progenitors. Now, we know that there are over 140 growth factors that have been identified in platelets. So these are just an example of like the top 5 or 6. Okay, animal studies, right? So if you're a rat and you get PRP, it's good for you. So there was a study by Wu in 2012. So these studies were reviewed in this paper, which is PRP for male sexual dysfunction, myth or reality. And so Wu looked at the rat cavernous nerve injury. So what they do on these rats is they go and they put them to sleep with ether, probably. That's at least what when I used to do kidney transplants on rats, that's what we do, is put them to sleep with ether. And then they go and they dissect out the penis and they find the cavernous nerve, right? The nerve going to the penis. And then they crush the nerve. So they use a hemostat and they crush the nerve. And then they inject PRP or drop PRP right onto that area of the nerve. And then they sew up the rats. And the rats are amazing. I don't know how much you guys know about lab rats, but rats have amazing immune systems. Rats rarely, if ever, get sick. And so you can kind of do that even in a non-sterile fashion in rats. And then they sacrifice the rats about 4 weeks later after checking their intracorporeal pressure. Now, I don't know how they stimulate the rats to generate erections. And I wasn't clear from those papers. And that is definitely not a job that I would want in the lab, to figure out how to give rats erections. But somehow or another, they checked the intracorporeal pressure and they found that it was 30% higher. See, I see Taylor blushing. Are you thinking about how you would get a rat to get an erection?
I have no idea, but yeah, that's what I was
You've probably
thinking
gone
about.
out with some guys that were rats, right? Sorry. Just teasing you. All right. And what they found when they took out the penis and sectioned it up was an increase in myelin on pathology, right? So you want to see if there's improvement in the nerves. Now, the question is, you're going to produce myelin anyway if you're crushing the nerves on a rat. And so they saw an increase in myelin versus controls. So that's one study. Okay. Another study was done by Ding, which showed that PRP effect on the regeneration and restoration of cavernous nerve damage. And they also found improvements in the intracorporeal pressure and improved myelination of nerves. But they found a small number of animals. Now, you know, there are a lot of rats out there, so they should increase the number of animals that they're doing. But obviously, these are difficult experiments and they're expensive to do. But I have some open space behind my house, and I have a number of rats that they could potentially use for these experiments if they're interested. Okay. The third study was also by Wu, where they optimized PRP production, and they concluded in these rats that PRP contains growth factors and promotes the recovery of erectile function in a small sample of rats. Here again, small sample of rats. Okay, so, but we're not really interested in fixing rats. We're interested in fixing humans. And so this group in Moscow or in Russia of Epifanova in 2013 to 2015 had, let's see, 75 patients. Okay, they broke it up into 3 groups. One group, they used PRP activated with calcium chloride. Another group, 30 patients with PRP activated with calcium chloride and PD5 inhibitors. And then another 15 with inactivated PRP. So PRP without calcium chloride. They did 3 weekly PRP injections, and they looked for increased peak systolic velocity, resistance index, and Shim and SEP scores. And they found that in all 3 groups, there was an increase in all of those factors. They were able to conclude that PRP contains growth factors and that there were no adverse outcomes from these things. But the studies suffered from the fact that there were no placebo groups and no long-term results, right? So those of us who do Gainswave know that it takes 4 to 6 weeks for us to get improvement in erectile function, typically, right? So you're growing blood vessels, and blood vessels take at least 4 to 6 weeks to grow. So the idea that after 3 weekly PRP injections, you're going to see a lot of improvement, I think is a little far-fetched. I think that they should have done, I personally would have spaced out the PRP injections maybe every 3 to 4 weeks. And I would have taken a baseline measurement. I would have taken those measurements again, maybe at 1 month, 2 months, 5 months, 8 months, to see what the long-term implications of these PRP injections are. The other thing is, like I said, you have to figure out what the concentration of vascular endothelial growth factor is and what your concentration of platelets are, because otherwise you're dealing with totally different doses in these patients. Okay. The other study was by Ethan Matz, who I think is a medical student at Wake Forest, but he works with Ryan Terlecki, and Ryan works at Anthony Atala's lab at Wake Forest, and Wake Forest really cranks out probably the best regenerative research in the world, them and Tom Liu at UCSF. And this is a study on 17 patients over a period of 5 years from a bunch of different indications, erectile dysfunction, premature ejaculation, incontinence. The only real conclusion from this study that anyone could make is that there were no adverse effects on those 17 patients from PRP. Their erectile dysfunction patients did have an increase in SHIM score by 4 points, but the sample size was so small that it was really kind of irrelevant. So those are really the two published PRP studies. And so if you hear people talk about, well, I use PRP and that has amazing results and it does this and it does that, you know, that's great. And those people can be right. I'm not saying that they're wrong, but what I'm saying is it's not really supported by any data that's in the published literature. And so here again, as a group of providers that treats erectile dysfunction and has PRP as a potential tool that we can use for our patients, I think it behooves us to begin to pull together to start doing these studies. And I'm working with Charles Runnels on pulling together at least one study on PRP that will begin to look at those kind of things in a very scientific way, where we're looking at vascular endothelial growth factor concentrations. We're looking at total number of platelets, so we can begin to try to standardize, you know, what is the dose? How many times do you need to do PRP? My own personal thought, which really isn't backed up by any hardcore evidence, is that it's best to start with Gainswave. You know, maybe after 6 Gainswave treatments, when you've activated stem cells and blood vessels are starting to grow, then you can use some PRP. I use at least a single spin kit with 22 cc's, and I find that it's working pretty well. Patients are pretty happy, but it hasn't been miraculous for me. But to conclude from this very recent review of the current literature on PRP, there are no common protocols, but this is safe, but still experimental. And you should talk to your patients about the fact that this is experimental and have that on your consent. The PRP is thought to work through regeneration of the endothelium, of amplifying smooth muscles and connective tissue, but the data that's currently available are insufficient to make a systematic review. And we as a community, if we want to promote these type of techniques, should pull together, like we did for the SWEET study, to conduct large placebo-controlled studies, or at least large studies where we can compare different techniques. Okay, so article number 2 was...
Dr.
Yes.
Brandeis, before we move on, we have a couple of questions, if that's okay.
Absolutely.
Okay, cool. So what about the timing of putting blood into the centrifuge for PRP?
I'm not quite sure what that means.
Let me clarify. So the rep for our PRP system taught us to get the blood in the centrifuge ASAP after drawing it, and then it could sit for 3 or 4 hours once spun. Dr. Runnels says to suggest waiting to centrifuge until you're ready to inject? What is your common practice for that?
We try not to waste too much time, but I don't know the specific reason for any of those things. So right after, our centrifuge is right next to our blood draw chair. And so as soon as we draw the blood, we put it in the centrifuge. And then once it's centrifuged, it doesn't sit around too long before we draw it out.
Okay.
But I don't have a specific technique more than that.
Okay, sounds good. And then I think I know the answer to this because we're still gathering data, and all of this data is inconclusive until we get a large study. But how about you recommend incorporating PRP from the very beginning? You don't recommend incorporating it starting on like treatment 3, correct?
My personal opinion is that if I'm going to use PRP, it's usually after 6 or 12 Gainswave treatments.
Got it.
I do not use it at the beginning of treatment.
Okay.
It's like when you put fertilizer down, like you want to wait till the tree is a little bit bigger and then you put fertilizer down. You don't want to put fertilizer down and then plant the plant.
Got it. That makes a lot of sense. Alrighty, I think we're ready to move on to our next article. So if you have any questions for Dr. Brandeis as we review the article, please post them in the comment section.
Yeah, great. All right. So this is a systematic, I didn't put the title of the article, but let me see, I'll show it to everyone. You can see it. Okay, this is a systematic review of human trials using stem cell therapy for erectile dysfunction. And this comes out of Ranjith Ramaswamy's lab, and that's at University of Miami. So Ranjith is one of the academic erectile dysfunction thought leaders, and he's running a placebo-controlled study on shockwave therapy for erectile dysfunction, and he runs most of the shockwave therapy sessions at the Sexual Medicine Society meeting at the AUA. So he's kind of the academic authority on shockwave therapy, and I guess also now on the uses of stem cells. So stem cells are being experimented on in cardiomyocyte regeneration and repair, in Parkinson's, in dementia, in tendon, bone, and cartilage regeneration. There are stem cell clinics kind of everywhere you look these days. But when I talk to my patients and they ask me these questions, I tell them, listen, if somebody tells you that they really know what's going on with stem cells, I tell them to run as fast as they possibly can in the other direction, because I really don't think anyone knows very much about stem cells, how to use them, exactly what to use them for. And I've been in communication with Tom Liu and also Anthony Atala. Anthony Atala probably someday will win the Nobel Prize for his regenerative work at Wake Forest. And if guys like Tom Liu and Anthony Atala don't know what's going on with stem cells, then really, honestly, nobody does. And if someone says that they really do, I don't believe them. And we'll go through the studies that show that how much there is a lack of knowledge. Okay, so one study was from Haar, 2018, and they looked at patients' status post radical prostatectomy, 6 to 18 months. And so you can get stem cells from a couple different sources. You can get them from adipose tissue, fat tissue. The advantage of those stem cells is that fat cells don't reproduce very much. And so they're relatively, even though they're old, they're relatively new stem cells. You can get stem cells from bone marrow. The advantage of that is that they reproduce fairly frequently. They split fairly frequently. The disadvantage is that they've split frequently over a long period of time. I mean, if you have a 70-year-old patient, you have 70-year-old stem cells. And then the other source of stem cells are mesenchymal stem cells from the placenta or from amniotic fluid or from birth, some sort of form of birth waste, Wharton's jelly, The advantage of those is they're brand new. The disadvantage is that they're somebody else's. The advantage of that is that they're easy to get. So these are adipose-derived regenerative cells. So basically, guys undergo some mild liposuction, cells down, and somehow or another through gradients, they're able to remove out the adipose stem cells. In this study, there were 21 patients. Follow-up was at 12 months, and they showed that in half of the patients, there were erections that were sufficient for intercourse. The issue is it wasn't a controlled study, and we don't know what percentage of those patients were actually going to recover erections anyway. And we don't really know the quality of the nerve sparing on those patients. And there was a mild increase in shim score from the beginning of the study to the end of the study of about 8 points. Now, we all know from using the shim score that you really have to increase your shim score by about 4 points to show any sort of significant clinical difference. So I think that the conclusion from this study is that it probably didn't do very much. Okay. Levy et al. In 2015 looked at a whopping 8 patients at a private practice in Coral Springs, Florida. Well, good for them, right? They're a private practice. They're doing clinical research with 6-month follow-up, and they used placental matrix mesenchymal stem cells with a single injection of placental matrix mesenchymal stem cells, and they did a penile duplex ultrasound at 6 weeks, 3 months, and 6 months, and they found an increase in peak systolic velocity that was fairly significant, which, you would say, wow, well, that's pretty good, but there was no change in the International Index of Erectile Function or the penile length or the penile width. So I don't quite know what to tell you from this study, other than it's a good first effort with a single injection. I think that many of these treatments, like if you give your trees fertilizer one time and hope that they're going to turn into great big trees, I think you're fooling yourself. I think a lot of these treatments are going to need to be repeated a bunch of times. And the fact that the peak systolic velocity, it's really, I don't know how many of you have done it, but it's really difficult to measure peak systolic velocities in the penis. There's a lot of variability in terms of these measurements. So to say that the measurements are definitive, I think is optimistic. And the fact that there was no change in the International Index of Erectile Function or penile length or width says that maybe there was a minimal effect on this. Okay. There was a group in Korea in 2010 that looked at diabetics, and they used umbilical cord mesenchymal stem cells with 12-month follow-up. And they found that there was maybe an increase in morning erections, but by 1 year, only one patient was having adequate erections. I think there were 6 patients in this study. So here again, not whoppingly big numbers and not a very sophisticated study. And then there was a group in France, okay, with 12 patients with bone marrow derived stem cells. Okay, so these are taken from the iliac crest using a bone marrow biopsy, which I remember back in medical school was a fairly uncomfortable or severely painful procedure. And they intravenously infused 1 billion cells. So instead of injecting them in the penis, which I think was what I would expect, they injected them intravenously, and they found that the IIEF-15 erectile function and satisfaction scores increased, and then the effect peaked at 1 year and slowly declined. So I find it hard to believe that injecting stem cells taken from the hip into the bloodstream is going to somehow magically improve erectile function from radical prostatectomy, that these cells are going to magically find their way down to the nerves in the pelvis. I mean, These are cells that are already somehow in the bloodstream because they're in the bone marrow. So I don't quite understand why these stem cells would have worked. You know, these stem cells are already in the body. Okay, so I'm not a big fan of that paper. You know, that's not just because it's from France. It's because of the science that I'm not a big fan of the paper. And then another group, there's nothing wrong with France. Al de Muir. So he looked at diabetics, and these were also bone marrow-derived mesenchymal stem cells in a whopping 4 patients. And they looked at 12 months out for efficacy. 3 of 4 patients improved their IIEF 15, and 4 out of 4 in the erectile hardness score. I don't know if you guys know what the erectile hardness score is, but it's a 4-stage assessment of erection. So 4 would be like you were when you were 16 or 18. 1, it would be, you know, no erections, and then 2 and 3 are somewhere in intermediate. So it's a very subjective score. It's not a very accurate score. So here again, I'm just reviewing the published literature. Okay, so as you can see for stem cells, there is sparse data, both for PRP and for stem cells, you know, much worse for stem cells. The theoretical improvement from stem cells is due to the paracrine effect. Okay, so what does that mean? It means that these stem cells don't actually take up residence and grow. So if you tag them with radioactive monoclonal antibodies and see if they stick around for about 3 or 4 days. And then usually after 3 or 4 days, they disappear. So it tends to be the cytokines that they produce and the growth factors that they produce that are stimulating the growth of other stem cells or other cells that do the work of improving blood flow rather than the cells themselves growing in place. There is a desperate need for more studies. I would be happy. I have the clinical research infrastructure. I have, I don't know how many of you have met Dr. Scott Liu, but he is a MD and also has a master's in clinical research from UCSF. We're working on our 4th IRB approved clinical research study now. And, you know, certainly if we want to get a group together to look at stem cells, or we want to get a group together to look at PRP, and we want to standardize some protocols, I can certainly coordinate these things through BrandeisMD. And if more people are buying Affirm and Affirm Science is making some more money, I'm sure I can talk to the leadership of Affirm and get some more money for doing these kind of studies. But when you're talking to these patients, be careful of what you promise. Especially these days, patients are pretty sophisticated. They'll go out on the internet and they'll say, oh, you know, I saw Dr. Brandeis. I saw his journal club, and I'm familiar with the data that's out there. So when I talk to patients about stem cells and I talk to patients about PRP, I'm very open about what it is and what it's not, and what you can expect and what you can expect, and what the pros and cons of all the different techniques are. And for those patients that want to proceed, they proceed. And for those patients that don't want to proceed, I never push them into those kind of things. You know, you want to set proper expectations. You want to be very open and honest with patients about what you're giving them. Let's see. And, you know, like I said, I have, for my stem cell patients that I've done in the past, I had a 3-page consent that included the entire contents of the Sexual Medicine Society of North America position statement on stem cells. And, you know, fortunately for us, there really have been no negative side effects of either stem cells or PRP. So I tell patients, you know, listen, if you're interested in doing it, it's time, it's money. But fortunately, there are really no negative side effects that we have been able to identify. Okay. So I hope people have some questions or some comments. I really appreciate everyone tuning into these journal clubs. I think it's really important that we as a group of Gainswave providers are up to date on the most brand new and up to date information about the things that we're doing for our patients. You know, one of these articles was from 2020, the stem cell one, and the other was from 2019. So you can't really get too much more up to date than that. It reviewed all of the literature for both stem cells and for PRP. So if anyone asks you about anything from stem cells or PRP, you can just pull out these two papers or tell them to take a look at this journal club, or, you know, talk about the studies, but you are completely and totally up to date. And I think that's about all I have to say this morning.
Awesome. Thank you, Dr. Brandeis. We do have a few questions. And if you have any other questions for Dr. Brandeis while we have him, please post them in the comment thread in the live stream. So our first question, also Dr. Brandeis, so if we want to get, if people are interested in participating in some sort of study to further clarify the effectiveness of stem cells, they should email you at research@BrandeisMD.com.
Yeah, well, I mean, why don't you research? I mean, if there are a bunch of people out there that are interested, email me at research@BrandeisMD, BrandeisMD.com. And if we can get 5 or 10 practices that are interested in doing a stem cell study, then we can contact one of the stem cell providers to see if they're interested. And if they're interested, you know, if my group does 10 patients and 10 other groups do 10 patients, then we have a study of 100 patients. I mean, that's, for stem cells for ED, that's huge.
Right.
And I'm a multimodality guy, right? So I talk about the 6 things that you can do to improve the health of your penis, to get better erections. I talk about boosting testosterone. I talk about nitric oxide boosters. I talk about PDE5 inhibitors. I talk about Gainswave. I talk about vacuum devices. I talk about PRP or stem cells. So it's not just like give stem cells and hope for the best. It's, you know, use one of these tools in the appropriate patient to get an outcome that meets the patient's expectations. Mm-hmm. And I think that's how it has to be integrated into what we do. It's not one size fits all. And that's one of the things that I'm really hoping that I can accomplish through this SWEET study, is to use the data to individualize patient outcomes. And so that's why it would be so great. You know, that's why we ask about PRP use and stem cell use in the SWEET study. But if we can create a stem cell study or a PRP study or both, then we can begin to integrate all of those data sets into a single kind of artificial intelligence algorithm that we can use as providers to provide the best information and to get the best outcomes for our patients.
Absolutely. Okay, so moving on to our questions from providers. In your opinion, what source of stem cells are most promising for the treatment of vascular ED? Subcutaneous fat, bone marrow, embryonic, etc.?
Okay, so I think that's a great question. What do I think? I think that, okay, so when my wife was pregnant with twins, she went to the orthodontist and she needed some teeth movement. And so she had braces put on when we had twins. And in 9 months, she had the braces taken off before we delivered the babies. And the orthodontist could not believe that her teeth had moved so quickly. He said her teeth moved 3 times faster than any other adult he had ever seen. And the reason is because she had so much growth factor floating around her body because she was pregnant with twins. And so I kind of have to believe that the stem cells from umbilical fluid, Wharton's jelly, the placenta, one of those areas is going to be more complete, more full with growth factor than old fat or old bone marrow. Now, the question is, where is the best place to get that get those cells or get that fluid. And I'm thinking personally that it's probably going to end up being amniotic fluid or maybe an exosome cell line, right? Exosomes are the vesicles that cells give off that are filled with growth factors and DNA. And so my personal opinion is somewhere along the line, we're going to figure out exosomes or amniotic fluid, and that's going to be the best source.
Mm-hmm.
But I don't know.
That's a crazy story.
Yeah.
Okay. Question.
It's not a good reason to have twins to improve your.
Yeah, to get straighter
There's
teeth.
a lot of diapers to move your teeth.
Yeah. Okay. So what size needle do you inject the stem cells with, and how do you manage the pain?
So I always inject with a 30 gauge needle into the penis, and I use BLT cream on the penis, and patients tolerate that really, really well. 30 gauge needle, you can distract the skin with your fingers, kind of roll it between your fingers, and it's not really uncomfortable. It's especially going through the skin. Now, going through the tunica, I don't know if any of you out there have given yourself a pee shot. I think if you're a guy, that you should. If you're giving patients a pee shot, you should give yourself a pee shot. At least you should know what it feels like when the needle goes through the skin and through the tunica. The skin is not too bad. The tunica does smart a little bit, but it's not too bad. Is that too much information?
No, not
Okay.
Report back once you do. We want this to be an open discussion.
Yeah.
So, okay. And then do stem cells only need 2 injections, one in each corpus cavernosum?
Okay. So when Charles teaches about the pee shot, he teaches, I believe, 5 injections. So 2 on each corpora and 1 in the glands. Okay. I personally believe that you don't need 2 on each corpora. I think 1 on each corpora is more than adequate. And whether you do it on the glands or not, I think that's debatable. I don't think anyone's ever shown data that it's better or worse. But the glands as a different blood supply than the corpora, right? The corpora are the erectile bodies. That's where your erections come from. The glands, or especially the area down in the frenulum, has more of the nerve tissue, the sensitive tissue. You know, I think that's a very difficult study to do to prove that that improves sensitivity. And I've never injected in the frenular area, but I have injected into my own corpora. And even if you inject in one corpora, even though they're separate corporal bodies, there is communication between the two. So if you do it under ultrasound, you can see the blood flowing from one side to another. So theoretically, you really only have to do 1 injection. I personally do 2 injections, 1 on either side, and then make sure that you hold or clamp the base of the penis. So I use a Cunningham clamp at the base of the penis to make sure that the platelets don't migrate. Because if you inject platelets into a large vascular space, then they're just going to float away and go back to the rest of the body. You want to make sure that they stay where you're injecting them.
Okay. Yeah, that's very good advice. Okay. And then I think that's it for our questions. We do have a provider who commented that he has a study from Translational Medicine in January of this year with 140 patients. And he wants to email the link, so you could also take that.
Yeah, that'd be great.
Yeah, I'll send that over to you, and then we can post the findings to the rest of it. But I think we're actually right on time. So thank you so much for joining, Dr. Brandeis. You can reach out to Dr. Brandeis at research@BrandeisMD.com, and remember to get Affirm Science. And then the Vitality Connect and Gainswave Practice Growth Workshop is also coming up April 2nd and 3rd of this year. So don't forget to book your travel and go to shop.com to find out more. Thank you so much, Dr. Brandeis. This was super helpful.
Awesome. So Taylor, I think it may not be 2 weeks, because in 2 weeks, I'm going to be at the Southeast section of the American Urologic Association, unless they cancel it because of coronavirus. Mm-hmm. But I think we should do our next one on maybe Peyronie's disease.
Oh, I'll put up a poll in the Facebook
Yeah, why don't we
group.
put up a poll? And also, you know, the thing is, like, if you have other articles or other topics or subjects or any of those kind of things that you're interested in reviewing, or if you want to be the guest journal club person for the week, uh, be my guest. I think it should be an open forum for all of us to participate and contribute, but I'm more than happy to do the early heavy lifting.
Awesome. Thank you so much. So let's plan on doing it in 3 weeks on Peyronie's, and I'll throw up a poll to make sure that resonates with all of our providers, but I have a feeling it will. And if you have any topics or would like to be a guest, please email me at taylor@vitalityconnect.com. Awesome. Thank you, Dr. Brandeis. Bye, everyone. Have a great
All right.
Friday.
Thank you, Taylor. You too.
Bye.